This is the 1 Million Lives podcast by Laerdal. Listen to healthcare professionals, healthcare educators, and survivors share their best practices and what they've learned from these experiences. At Laerdal, it's our goal to help save 1 million more lives every year by 2030. One life at a time. The story of today's guest began years ago in New Zealand, where she started her life's journey as an ordinary midwife and later ended up with a PhD in midwifery. She also got to experience being appointed by the New Zealand Minister of Health to be the first chair of the Midwifery Council of New Zealand. She has been the head of the School of Midwifery and later Director of Learning and Teaching before becoming a professor of midwifery at Otago Polytechnic in New Zealand. After holding many different voluntary positions at the International Confederation of Midwives, or ICM for short, she ended up as the chief executive of the organization, which made her move to the ICM headquarters in the Netherlands.
Welcome to the 1 Million Lives podcast, Sally Pairman.
Thank you, Bjorn. It's a pleasure to be here.
Why did you decide to become a midwife?
I didn't. It was a kind of a funny thing, really. I didn't have any idea about midwifery. I didn't know what it was. When I left school, which I left quite early, I wanted to leave school and I took myself off to university and I did a bachelor's degree in English literature, highly useful. and then I thought, well, I better figure out how I'm going to earn some money. So then I decided to do nursing, and the reason that I became a nurse was only because I wanted to travel. So I thought that it would be a job that would take me around the world. But in our final year of nursing, we had a 6-month component of our program that was maternity nursing. And we went to the maternity hospital for our placement. But we had a teacher who was a midwife from Britain, and she told us all these stories about how she was a midwife in London during the Depression. And I was really taken by her and by her stories, and I thought it sounded really interesting, riding around on your bicycle and going to people's homes and looking after them in their homes and home birth and that sort of thing. And I'd had this opportunity to go to a home birth, which really, really amazed me. And then when we were doing our placements at the maternity hospital, the midwives were really impressive. They were absolutely terrifying, I should say, because they were quite scary for us students. But what I could see was their autonomy and the way that they were in charge of everything, and it just really appealed to me, actually, that the idea of having that sort of I didn't fully understand it then, but that whole scope of practice and having that autonomy and being able to get out there and provide care, and also, of course, childbirth on the whole, it's all about happy families and positive experiences usually, and that was really, really nice and quite a nice contrast to working with people who were largely sick, which was more my nursing experience. So that was it. I took myself off, and also, of course, in those days in New Zealand, you really couldn't become a midwife very easily. So it was a perfect excuse to travel. So I went off to the UK and did my midwifery education over there, which was fantastic. So that was it.
I assume the International Confederation of Midwives, or ICM, is well known among the world's millions of midwives, but for the many who is not, can you explain a bit to us what the ICM actually is and what it stands for?
Okay. So we're a confederation, which means that we have many members. And our members are midwives associations. So they are professional associations for midwives in countries. We've got 140 member associations around the world in 119 countries. over every continent. And really our work is to work with those associations, to support them, to represent them, to strengthen them. And we work with them across the 6 regions of WHO, so Africa, Americas, Western Pacific, Eastern Mediterranean, Southeast Asia, and Europe. And together, all of these associations themselves are representing over 1 million midwives globally. So we're representing them, and they are representing all of the midwives in their country. And I guess together, what we're really trying to do is to raise the standard of midwifery so that women get, high quality services, and that midwives actually also get the respect and environment that they should have as part of the health workforce. So that's largely what we do. We also work, we're also accredited to the United Nations, to WHO, and we work closely with UN agencies and other partners, other organisations in our work, and we run quite a lot of projects that we get funded for, as well as our real core work of strengthening the midwives associations.
Are you also involved in creating a standardized educational programs for the midwife schools around the world?
Yeah, absolutely. Thank you for reminding me about that, because it's an important part of what we do. We set the global standards. So first of all, we define what a midwife is, and there's an internationally accepted definition of a midwife and an internationally accepted definition of the scope of practice of a midwife. So what a midwife can do on her own responsibility. And then the ICM also sets global standards for midwifery education and global standards for regulation, for midwifery regulation. And we have also global standards for midwifery competencies. So we define the competencies that every midwife should have, the minimum competencies that every midwife should have in order to be able to practice across the scope. And that is very important and incredibly useful, I think, in countries. We know that many countries do follow the ICM and try to work to the ICM standards when they're setting up midwifery education and so on.
You have already mentioned that ICM is working closely with several United Nations organizations, but I understand you are also working with the International Federation of Gynecology and Obstetrics, or FIGO for short, and the World Health Organization, or WHO. One of the things I understand you are focusing on is the United Nations Sustainability Development Goals. One of these goals, I understand, are to reduce preventable maternal mortality, or reducing the number of mothers dying during the last 42 days of their pregnancy. How is that project going, Sally?
Well, we're not very far along. I think it's not really quite to zero. So the SDG, or the Sustainable Development Goal target 3.1, which sits under the goal 3, which is about good health, the target is to reduce maternal mortality to less than 70 maternal deaths per 100,000 live births by 2030. So we are already very close to 2030, and we are not making really good progress. The World Health Organization have just released a report on this, and it looks as though in the first few years there was reasonable decline, but it's really stagnated in the last few years. And so the decline is very, very slow. And at this rate, we're certainly not going to reach that goal. We're going to be a very long way away from it.
In the spring of 2023, WHO presented its report on maternal mortality. It was not really a happy story, as it showed that somewhere in the world a woman is dying every second minute due to problems related to pregnancy or childbirth. The report shows that the mortality is either stable or increasing in all regions of the world. According to this report, 287,000 women lost their life during pregnancy in 2020. In Europe, North America and Latin America, maternal mortality increased from 2016 to 2020 by more than 15%. Why do you think it is so?
Well, I think there's many factors here, and that report, does bring attention to some of them. We know, for example, that still the majority of the worst maternal mortality rates are in sub-Saharan Africa, and in countries where there is a lot of poverty, and then compounded by conflict and various humanitarian crises. I think they're really making things worse. So still about 70% of all maternal deaths are in sub-Saharan Africa. But, and that's countries with humanitarian crises, really high maternal mortality rates, higher than anybody else, double anywhere else. And I think what we see is huge inequity. We've got lack of investment in maternal health services. We've got very poor health systems, for a start. Countries that can't afford to invest in health, and then within that, they're not investing within maternal health services. We've got a huge global shortage of midwives, over 1 million midwives short at the moment. Many women have lack of access to services, so they don't get antenatal care that they should be getting. They're not getting family planning care, so they don't have access to family planning methods. They can't space their births, and that, of course, contributes increases their chances of having some complications or from dying, usually from bleeding. We have a lot of health system failures, so there's poor quality care. And I think there's another WHO report that shows that actually one of the highest reasons for death these days is poor quality, even higher reason than lack of access to care. There are shortages of supplies. There's not much accountability in the system. Then we've got individual, people who don't have enough money. They're not earning. They don't have access to education. There's all kinds of inequities for race and ethnicity. And then there's biases, low prioritization of rights of women and girls. Women are still second-class citizens. And then if you're a black woman in America, you're even lower. And just going back to the increases in the US, there's a huge increase in maternal mortality for black women and women of colour. And that's to do with bias, and that's to do with, inequality within the way the system treats people. And then, of course, we've got external factors like climate change, wars, refugees, COVID. All of these factors are contributing to the very, very slow decline in maternal mortality.
So what you are saying here is that, in your opinion, gender equality issues can actually also play a major role here?
Yeah, not just in my opinion. I mean, this is well documented that gender inequality is a huge barrier at both sides of it, actually. For women and girls, it's a barrier in terms of the kinds of quality of services that they can get access to. And for midwives, it's actually also a barrier because within the health system, it's a women's health profession on the whole. There are some men in midwifery, but it's largely women. And they're caring for women. So they are already lower in the hierarchy, if you like, within the health system because it's a women's profession. And then the group that they're caring for are women who are already lower in the priorities in most countries. And so it's a double whammy, if you like.
You're listening to 1 Million Lives, a Laerdal podcast.
Why, Sally, is the role of the midwife important?
Well, I think because it's such a very specific role that midwives have a a discrete role compared to other health professionals. So what midwives do is that they provide care to women and their newborns, but to pregnant women to start with, across from pre-pregnancy right through the pregnancy, through the labour and the birth and the postpartum period up to usually around 6 weeks after the birth. And they're unique in the sense that they've got two clients, if you like. They've got the mum and the baby, and they're always working with the mother and the baby together. And midwives bring a very particular approach to their care. So they work from a strong philosophy, which is about birth, childbirth, new birth, being part of life, that women's bodies are designed to give birth. So it's a physiological process rather than a pathological process. So it's not an illness; it's a health. It's a health event, a life event, and midwives are coming with the idea that this should be around the woman and her family, and what is it that they want. So the experience that they want to have, they should be at the centre, making the decisions around what happens on the basis of good information, of course, but in a very respectful way that promotes physiology, that uses all of the incredible research that we've got, and brings that to play to make sure that women do get good quality care. But also midwives are able to act in emergencies. So they're very good at looking at what's going on, making assessments, making diagnoses, intervening when necessary and not intervening when they don't need to. Working collaboratively with obstetricians and paediatricians, especially, making sure that women get access to higher levels of care or, more specialised care, such as from an obstetrician when they need it. But also midwives are able to do all of this on their own responsibility. So they can provide family planning care. They can do all of the assessments that are needed during pregnancy. They can, look after women during labour, and they can deliver the baby or help the woman to give birth to her baby. And if there's an emergency, they can manage that. So it's very, very important. And there's a lot of research that we now have that shows that if midwives are used effectively, they will seriously and significantly decrease maternal death, newborn death, stillbirths, and they will improve a lot of outcomes that we measure in these in maternity services. So they provide really, really good quality care. And generally speaking, midwives are in communities. They are close to where women live. Women are able to access them more easily if those services are supported by health services. I think they're incredibly important because of that role, but also because they can really make a big difference on their own. They can make a big difference. And they can, of course, make a bigger difference when they're working in a really well-functioning health system.
And since I'm a man and a husband as well, I need to ask you, in your opinion, do midwives have any focus on the partner of the pregnant mother, or do they consider them more of a hassle than a part of the birth process?
No, of course they have a responsibility. And I think the really important thing is that the midwife takes her lead from the woman. So who does the woman say is her family? Who does the woman want to be involved in her care? Who does she want to be with her? Those are the people that the midwife then has to interact with. And usually, of course, that is the partner, but not always. And the midwife is about supporting the family as defined by the woman, not as defined by us.
You told me that you are representing midwife organizations from 119 countries, but there are really close to 200 countries in the world. How do you plan to reach these countries with your programs?
Okay. Well, we've got 140 associations in 119 countries, and that means that some countries have got more than one, which we would just really like it if we actually had one in every country. But I think the there's again many issues about whether or not midwifery is actually recognised in a country. Who are the midwives, and do they have an association? And I think in many countries, midwives come from, it's after nursing, so they become nurses and then they become midwives. And our data, if you like, at the moment often doesn't really separate the midwifery workforce from the nursing workforce. So it's quite hard to get the numbers right and to know how to access the midwives. And the midwives in many countries are called nurses, so they don't necessarily see themselves as a separate profession. And if they do see themselves as a separate profession, then they need to, and they usually want to, set up their own midwife association for their support, and then they could join the ICM. But I think there's sort of many steps. So there's, one, do they have midwives in a country? Or is maternity care provided by nurses and doctors and not by midwives? Probably that's pretty unlikely. I think that probably there are midwives, but it might well be that they are not recognised as a separate profession. They don't necessarily recognise themselves as a separate profession, and they haven't yet set up an association. So through our advocacy work, we're trying to bring attention to the need for midwives, and we've got a big global advocacy campaign that we're working on at the moment with many partners. It's called the Push campaign. And one of the things that we're trying to really bring attention to is this global shortage of midwives, but also the evidence as to why a country should have a midwife, why they need a midwifery workforce. And we're trying to bring attention to the need for appropriate education for that midwifery workforce. And then all of the other factors that need to happen. So you've got to, first of all, have an educated midwife, then they have to be registered and regulated, and they need to be properly deployed in the health system so that they're working effectively. So there's many different components that need to be in place. But if a country does have a well-organised and integrated midwifery workforce, then they can start to actually improve the quality of care. And there's quite a lot of evidence now that actually, if you did actually use midwives, if 100% of women could access a midwife, midwives would, the maternal mortality rate would drop by 67% if there was universal health coverage of care from a midwife. So, there's a lot of reasons why it would be important for countries to invest in midwifery and in midwives. But getting attention to that, getting that understood, getting that prioritised, these are the challenges that we're facing.
As this episode of the 1 Million Live podcast is recorded in the spring of 2023, we should perhaps mention that early this summer, ICM is hosting a World Congress in Bali in Indonesia. And I understand that you have similar congresses every third year.
We do, that's right.
Do you already know where the next one is going to be?
After Bali, it's going to be in Portugal. And after Portugal, it's going to be in Abu Dhabi. It's very unusual that I would know this for the next two. But we are well organised, and that's all down to COVID.
Please tell us a bit about what you plan to touch upon at the conference in Bali.
Well, I mean, the way that our congresses go is that it's an amazing face-to-face opportunity for midwives. And if you've never been to a midwifery conference, I would encourage you because they're pretty incredible. Midwives love getting together and talking about practice and actually recognising how much they have in common. It doesn't matter where they come from. They share an awful lot because of the very specific work that they do. And so the Congress is a big opportunity for midwives to talk about their own research, to talk about their own practice. So we don't just go for research, we also ask people to talk on practice. They do posters. We have many, the scientific program is very, very robust. But as well as that, we will be having plenary speakers, panels each day, looking at different issues and people talking about that. We will have social events on the Saturday before the Congress. We're having a dance for women's empowerment. We've got midwives associations all practicing dances, and we're going to have a great big huge dance, which will be amazing. We will have our social night, our Bali night. There'll be many side events, side satellite events. So lots of partners. So WHO, United Nations, the UNFPA, the partners like the Gates Foundation, like FP 2030. Just trying to think. There's so many. Laerdal, all running lunch sessions, breakfast sessions. There's just an awful lot happening, and many opportunities for midwives to really learn, to update their knowledge, to find out new things. I think probably what they're most looking forward to is meeting up with each other again after 6 years, because we haven't been face to face since 2017 in Toronto. So it's exciting, yeah.
I was present at the ICM conference in Prague many years ago. It was quite a sight. The first day of the conference, a vast majority of the midwives came in their traditional national costumes from all over the world. It was quite a sparkling sight.
Ah, fantastic.
So, dear listener, if you are a midwife and you hear this after the 2023 ICM conference in Bali, at least you could look forward to the next global conference in Portugal. And if you are not a midwife, you might still have time to become a midwife in time for the 2026 conference in Portugal.
In 26, yeah. Great that you're helping us with our workforce shortage here, Bjorn.
Where is it in Portugal, actually?
It'll be in, what's in Lisbon? It'll be in Lisbon, yeah.
Well, good luck with the upcoming conferences, Sally, and thank you very much for joining us here at this 1 Million Life podcast by Laerdal.
Thank you, Bjorn. It was a pleasure. It's a pleasure. Thank you.
You have been listening to a 1 Million Lives podcast by Laerdal. You can find all our podcasts and access any bonus material on laerdal.com/podcast. The views, information, or opinions expressed are those of the guests and do not necessarily represent those of the institution they are affiliated with or of Laerdal Medical. If you have any suggestions for guests or topics we should cover, please send us a message on laerdal.com/podcast. We look forward to hearing from you.
Until the next time, goodbye from the Laerdal podcast team.